Project Echo. As you know, these sessions are held weekly, and this is the turn of the lower GI endoscopy session. Vikash Lala is on leave, and he's deputized his slot to Jessica, who's one of the fellows at Wits Donny Gordon. And she's given us a topic that's open to debate. And by its title, we don't really know what it is, but I think it's near the tail end where you put the colonoscope in. So we're going to hear a little bit more about that from Jessica, and we'll, I'm sure, see how it evolves and what exactly we're going to learn from the episode. So welcome everyone. Remember to post your questions in the chat, and at the end we will take questions. Jessica, over to you.
Okay, good afternoon, everybody. Thank you for the introduction. So I'm going to be talking this afternoon on an elusive enigma for the endoscopist, and then hopefully by the end of this presentation, there'll be some clarity on this topic. So I'm going to start off with a clinical case that Dr. Lala gave me. This is one of his patients from private, and he's Mr. M.A. He's a 55-year-old male. He's a metabolic syndrome and phenotype. He's hypertensive. He's got central obesity. He's got fatty liver disease. He was an ex-smoker. No significant family history in terms of GIT malignancies. He's not on any anticoagulation. He's on no significant sexual history, and why Dr. Lala asked that will be elucidated later on in the presentation. He had a previous C-scope done at another facility whose indication was for abdominal pain and constipation, and the referring surgeon found a cecal polyp with a depressed area and referred on to Dr. Lala for resection. So this is having a look at the C-scope. This is our terminal ileum, our cecum with the appendix, and then moving on to the cecal polyp, which is over here with the depressed area. It's been resected nicely, nice clear margins, snared out. And then on withdrawal, he came and he found this other polyp and in the rectum, actually at the dentate line, where the anus and the rectum joins. Okay, so anybody with a clue for the diagnosis? I was going to show a video. I think I'll show it to you at the end of the slideshow, just so that we don't have any technical issues. But can anyone guess the diagnosis of the rectal polyp? Okay, so no. And then we've got specimen A, which is our
Jessica, I'm going to suggest to you that
showed histopathological features that was in keeping with the tubular adenoma. Sorry? Prof?
It's okay, Jen. I was going to suggest it will be the same. It will be an adenoma, the same as the one in the it'll be a tubular adenoma.
Okay. So that's what Dr. Lala also thought, and then he got his histology back. So specimen A in the cecum was a tubular adenoma, low-grade dysplasia. There was no evidence of invasion. Then the rectal polyp came back as something very different. So the biopsy of the second polyp in the rectum at the dentate line showed histopathological features of a squamo-proliferative condylomatous lesion, with showing changes of anal intraepithelial dysplasia grade 2, with some areas that were actually progressing to high grade or grade 3. They then went on and did HPV subtyping, and it was positive for HPV-6, so that's our condylomatous subtypes, and it was negative for HPV-16, which we'll get to later. All right, so that leads us to our topic of today, which is anal intraepithelial neoplasia, or AIN. Just as an introduction, malignant tumors of the anal canal account for about 1 to 2% of the colorectal cancers. In Western countries, the squamous cell subtype is the most common, around 80 to 85%. And there are clear risk factors and precursor lesions that we're going to be speaking about today that have been identified, and are thus a topic and a target for screening purposes and intervention before they become cancerous. So they're commonly detected at the squamous columnar epithelial junction, also known as the anal transitional zone, where our patient's lesion was found as well. And this is a diagram showing the anal transitional zone, the dentate line, and the insertion of the puborectalis muscle. And this would be our whole anal canal, so from the anal verge up until the insertion. But most of our lesions are found in this area here. Okay, so I'm starting off with just explaining the nomenclature of AIN, because you'll get these reports back from the histopathologists and they use different terminologies. So we're going to start off with this. So they're graded from morphological criteria of increasing severity. So the first is you'll sometimes get a report saying it's negative for atypical squamous intraepithelial lesion. That's what the L is for. Then it can also be described as atypical squamous cells of undetermined significance, low-grade squamous cell intraepithelial neoplasia lesions, and then atypical squamous cells that cannot exclude high-grade lesions, and then finally high-grade squamous intraepithelial lesions. Okay, so this is a two-tiered classification. So AIN1 is equal to low-grade squamous cell intraepithelial lesions. AIN2 is then subdivided based on its positivity for P16 staining. And if it's positive, that's considered a high-grade lesion. And then if it's classified as AIN3, that's automatically a high-grade lesion. So this is just a nice slide to help you interpret your own histopathological findings when you get them back from the pathologist and how they're all equal to each other. This is just another table that you can use and showing all the different classifications and how they are equal to one another. Okay. This is a picture of the histopathology. So A and B are low-grade lesions, and then C and D are high-grade lesions. So you can see the atypical squamous cells here with large nuclear bizarre cells, reverse cytoplasmic to nucleolar ratios, are found in one layer of the epithelium, and then with mild spotty staining of P16 positive. So this would be an AIN2 lesion because it's P16 positive. So it's more on the high grade side. This is more low grade. And then these two are showing high grade lesions. So you can see it's involving much more, all three layers of the epithelium. And then it's densely positive for P16 over here. So looking at our risk factors for anal intraepithelial neoplasia, HPV infection is absolutely necessary, but it's not sufficient on its own to result in anal squamous intraepithelial lesions. Your high-risk strains are namely HPV type 16. 18 is also implicated. And then if you have infections with multiple strains of different HPV, that's also a risk factor to progress into anal squamous cell intraepithelial lesions. If you have concomitant cervical infection as well, this increases your risk in developing ASIL. And looking at sexual behavior, similar for both men and females, if you have receptive anal intercourse, if you have more than five sexual partners, and then if there's a concomitant infection at another site, so in females at the cervical region, and then again in females, assuming that there is concomitant infection, wiping from back to front may also increase your risk of developing anal squamous cell intraepithelial lesions. All right, now looking for the next big pillar of our risk factors, which is HIV infection. People living with HIV have an increased risk of all three stratospheres. So getting high-risk strains, number one, developing intraepithelial neoplasia, and of that intraepithelial neoplasia, getting the high-grade subtype, so all three. This is because they have impaired mucosal immune response, which facilitates HPV replication. And then another risk factor in this cohort is a low baseline CD4 count. So the natural history of anal intraepithelial neoplasia is not as well documented and characterized as the cervical cancer program. There's limited knowledge about the long-term natural history of anal squamous intraepithelial lesions. It's a dynamic process with lesions actually that arise and regress over time. So it's not like the cervical cancers, which start off as squamous intraepithelial neoplasia and then progress on a continuum to becoming cervical cancer. These tend to not follow the same pathway. So looking at low-grade squamous cell intraepithelial lesions, it's considered to represent a marker for a risk factor of high-grade lesions rather than a direct precursors. And there are certain risk factors that will increase your risk for progressing from a low-grade lesion to a high-grade lesion. And those are patients with HIV with low CD4 counts, anal human papillomavirus again, and the presence of multiple HPV strains. Okay, so in a study of around 177 HIV positive males, and specifically men who sleep with other men, there were 177 low-grade lesions at baseline, and only about 16% were reported to progress to high-grade lesions at follow-up. So they actually thought that these might not be progression to high-grade, but that the endoscopists may have actually biopsied an area of high-grade dysplasia close to the location of the low-grade dysplasia, rather than it being a true progression from low-grade to high-grade. And that 50% of these had already cleared in 2 years, so they spontaneously regressed after without any intervention. And then anal lesions showing evidence of low-grade squamous cell intraepithelial lesions may spontaneously regress. And then looking at high-grade lesions, true cancer, it's a true cancer precursor with the potential to progress to invasive anal squamous cell carcinoma. So these are direct precursors of anal cell cancer. They do also spontaneously regress, but less likely than your low-grade lesions. So only about 20 to 30% of those will regress, whereas your low-grade lesions, about 50% will regress. Infection with HPV-16 is the strongest determinant of persistence. So you increase risk of developing anal cancer if you have high-grade lesions. It once again is in HIV-positive patients, in females with the history of concomitant cervical or vulvar high-grade lesions or cancers, and then interestingly, recipients of a solid organ transplantation. Then this is one of the landmark trials, which is the Anchor trial. It was a 2022 NEJM, published in the NEJM, and it involved almost 5,000 people living with HIV above the age of 35 who had biopsy-proven high-grade lesions that were randomly assigned to have treatments or just monitoring for a median follow-up just above 2 years. And in that study, invasive anal cancer was diagnosed in about 9 out of 2,227 treated patients, and versus 21 out of 2,219 controlled patients, which means 173 versus 402 cases per 100,000 person years. So treatment reduced the risk of progression to anal cell cancer by 57%. And then the cumulative incidence of progression to anal cancer at 48 months was 0.9 versus 1.8% in the treatments and in the active monitoring groups. So there's clearly benefits in treating high-grade lesions. Looking at our clinical manifestations, most of our lesions are asymptomatic. There'll be sometimes pruritus, bleeding, or some discharge from the anus, and sometimes irritation tenesmus, but it's mainly asymptomatic. It can also show clinically as condylomata acuminata, which is a manifestation of low-grade lesions perianally, and they're clinically quite obvious. They're frond-like, they have a frond-like appearance, and then other low-grade lesions perianally are generally flat. In your history and examination, it's mainly concentrating on your HIV serostatus, what your CD4 baseline count was, what your viral load is, what is your sexual history, any other sexually transmitted infections, specifically a history of anoreceptive intercourse, previous HPV infections, any local symptoms, recreational drug use, smoking history, all of these risk factors that may promote HPV contraction. And then don't forget medication that with specific attention to drugs that associate with immune suppression. Then when you're examining them, looking at the perianal skin, you can do a digital examination, and then later I'll speak about high resolution endoscopy. And then just always remember as a general physician to please look for palpable lymphadenopathy and any other stigmata of immune suppression in your patient. This is a picture of some of the perianal lesions. So this is a bowanoid lesion. These are actually high-grade lesions perianally. Then the other 3 are low-grade lesions, all of anal intraepithelial neoplasia caused by HPV. So erythroplakic, leukoplakic, and then the verrucous subtype. So this is the only high-grade lesion perianally. Okay, so screening. So there are no randomized clinical trials that actually document the value of screening for anal intraepithelial epithelial neoplasia in our at-risk populations. And the rationale for screening relies on the success of the cervical cytological screening program in preventing cervical cancer. And like I said, initially we did have that Anchor trial that was published in the NEJM that did demonstrate benefits in treating high-grade lesions to prevent progression to invasive cancer. So who should we be screening? So people living with HIV, men who have sex with men, iatrogenic immune suppression, so solid organ transplant recipients, IBD patients on long-term immunotherapy on corticosteroids, women that have a history of cervical, vulvar, or vaginal squamous cell intraepithelial lesions or cancers, and then women with cervical HPV infection, and individuals with history of anogenital warts. So this is a table from UpToDate. And then I'll elucidate on some of the expert groups later on. And then timing and frequency of screening, there's no consensus on the guidelines. Some experts do say patients, if you're immune compromised, you can start screening from the age of 25. Others say that if you're immune competent, from about 40. And then the frequency is based on your cost-benefit ratio and expert opinion only. So 2 yearly if you're HIV negative, and yearly if you're HIV positive. The age at which you should stop screening is to be discontinued. It's not defined, and it varies according to your ongoing risk factors for that individual. So these are some of the expert groups. So year 2021, their guidelines state that if you have HIV and you're more than 35 years old, you should be screened. HIV negative men who sleep with men, women that have a history of HPV-associated genital cancers, solid organ recipients, and other immune-compromised individuals without HIV infection. Then patients who do not fall in any of these categories shouldn't be screened for anal cancer. Looking at the HIV Medicine Association of Infectious Diseases, Society of America, they give a moderate quality weak recommendation for screening with cytology in men who sleep with men, again, women living with HIV with a history of receptive anal intercourse or abnormal cervical pap smears, and then people living with HIV with genital warts. The Transplantation Infectious Diseases Community of Practices states that an annual anal cytology in solid organ transplant recipients, particularly those with a history of receptive anal intercourse, or if they've got cervical neoplasia, should be screened. Then the American Society of Colon and Rectal Surgeons recommends annual screening in high-risk populations. So their high-risk populations are people living with HIV, men who sleep with men, and female with a history of cervical intraepithelial neoplasia. So methodology of screening. So it's not typically palpable. You're unlikely to be recognized on routine DRE unless you have some of those perianal lesions. Cytology is traditionally used as the initial screening tests, and then patients that have abnormal cytology are then referred on to HRA to examine the anal canal and the perianus to identify areas of high-grade lesions to biopsy. So looking at how we do it, we use a water-moistened polyester fiber swab. We collect the cells prior to endoscopy or to anal examination, and you avoid lubrication because you want to preserve your cellular yield and your morphology. You can lubricate the patient after you've done your cytology. So the patient is then positioned in the left lateral position. You gently insert the swab until it cannot be advanced further. Then you know you've reached the rectum, and then you do a gentle circumferential swab, trying to get the full anal transformation zone. Then looking at our test characteristics, they're only best described in a certain cohort, which is men who sleep with men that are living with HIV. So it's not described in any other cohort. And in here, cytology has a sensitivity of about 83, but a very bad specificity of 45% to detect high-grade lesions. So it's got a very good negative predictive value, but a very poor positive predictive value. And this reflects the use of any cytological abnormality. So they send anything that's not negative for intraepithelial neoplasia. So atypical squamous cell lesions of undetermined significance, those that cannot exclude high grade, they all get referred to for HRA referral. So if you do have high grade lesions on your cytology, your specificity is actually very high for picking it up on biopsy. So if you pick it up on cytology being high grade, you most likely will get a high grade on your biopsy. Okay, so the performance data, like I said, for cytology is more limited in other at-risk populations, but I did find one study where 636 females with a history of lower anogenital tract squamous intraepithelial neoplasia also reported a similar limited positive predictive value, but a very good negative predictive value for anal cytology. So it's a good screening test. And then other screening tests that have been thought about are molecular diagnostics. So those would be testing for HPV, so PCR. And then the last two are your biomarkers for cellular proliferation. And at the moment, there's no clear benefit for any of these tests over anal cytology, and they haven't been established in our high-risk groups. So their use cannot be recommended at this present moment, and they may perform better in other at-risk populations where the prevalence of your HPV is lower. Then moving on to high-resolution endoscopy. So looking at, which is basically colposcopy, but in the anal canal. So you examining the anal canal and the perianus using a colposcope for lighting and magnification after the application of 5% acetic acid and Lugol's iodine solutions to identify anal lesions. You actually visualize the lesions that represent the source of the abnormal cells on the cytological screening. It allows for your histopatological grading of your severity of your disease. And the goal of the biopsy is to identify these high-grade lesions or invasive anal cancer, since these are going to be targeted for treatment. So the method is it's a gauze swab. You soak your Q-tip in 5% acetic acid. You insert the Q-tip into the anal canal, and it's applied evenly prior to visualization. And then the acetic acid produces a white appearance in the area of abnormal transitional epithelium. And then the most common endoscopic changes associated with high-grade lesions are presence of an aceto-white change. So normally a flat, slightly raised or thickened epithelium with abnormal blood vessels, which show a punctated or a mosaic pattern. Tissues that with these, the blood features, so aceto-white change and abnormal blood vessel pattern, that say negatively with Lugol's iodine, they are considered highly suspicious for high-grade lesions and should be biopsied. If they still don't take up Lugol's iodine, but they have low risk features, so normal vascular pattern, and there's no aceto-white change, you still could be missing a high-grade lesion. So there's a suggestion that if it still stains negative for Lugol's, that you should still take a biopsy. And this is just a picture from endoscopy. So this is the aceto-white change that you're looking for. It's very subtle. As you can see, it's easy to miss. And hence the word elusive, and it's an enigma for many endoscopists. I think many would miss this. And then looking at our atypical vessel patterns, so these are mosaic patterns, and then those coarse punctations that they were speaking about, which are high-risk features. This is a table that I got from a journal article, which basically states the sensitivity and specificity. So as you can see, mainly flat lesions, granular lesions, mosaic pattern, and then if they're Lugol's negative, is mainly high-grade lesions. Okay, then moving on to endoscopy. So your anal intraepithelial neoplasia can actually be detected during colonoscopy screening. That's the suggestion. The magnification power of endoscopy is much better than that of your high-resolution endoscopy. And your image-enhanced endoscopy using NBI, blue laser light imaging, is much more superior in visualizing the vessel and the surface pattern of these lesions. So why aren't we doing it more often? Some would say it's a very technically difficult area, and it's a narrow area that you can't visualize it adequately with an endoscope, but using retroflexion and a tip attachment, which I'll show you in the video of Dr. Lala's at the end of the presentation, and sufficient insufflation, your narrow areas in your anal canal and at that squamous columnar junction can actually be examined quite sufficiently. And then endoscopic features are actually similar to those of esophageal carcinoma, early esophageal carcinoma. So there is a suggestion that you can use the Japanese Esophageal Society endoscopic classification to determine the depth and extent of your anal intraepithelial neoplasia, because there's no classification for this currently. And this is a picture that I got from a Japanese article where they're using endoscopy to identify a lesion, a high-grade lesion. So this is in white light. This is the lesion. So it's a high, you can see it's nice and flat, nodular, and it's slightly redder than the background mucosa. And then on NBI, you can see the irregular vascular patterns that are similar to those of superficial esophageal carcinoma. Okay, moving on to the management of these patients. So prevention is always better than cure. Starting off with vaccination. In the United States Advisory Committee on Immunization suggests that HPV vaccines should be given to all females and males from ages 11 to 12. Vaccination can start as early as 9 and continue through the age of 26 and extends to all immunocompromised patients. The FDA has approved that HPV vaccines for adults ages of 27 through to 45 years old, and there's no catch-up vaccination that's not currently recommended for older adults. Okay, there are several types of vaccines which have been developed, and they vary in the number of the HPV subtypes they contain. We all know Gardasil 4. There's also Gardasil 9. It targets 6, 11, so the lower risk lesions. 16 and 18 are higher risk lesions, and then as well as 31, 33, 45, and 52 and 58. Just remember, these are prophylactic vaccines. They're designed to prevent initial HPV infection and subsequent HPV-associated lesions. So data informing the impact of HPV vaccination on anal lesions and anal cancers are much more limited than those of the cervical disease. So it's a very common question: should we still vaccinate patients with prior HPV infection? So it appears to attenuate vaccine efficacy for anal infection and disease if you've already had prior HPV infection. But we should still give routine vaccine. So because you should still routinely give your vaccination before the onset of sexual activity. However, that's not possible once you've already acquired it. And vaccination is still recommended as it provides protection against infection of other HPV subtypes that has not already been acquired, if that makes sense. Okay. So looking at our low-grade, so our treatment of our high-grade lesions, none of these approaches are approved by the FDA except for radiofrequency ablation. And data on the efficacy of different treatment agents to reduce or clear these lesions are quite limited. So for individual smaller lesions less than 1 centimeter at the base, or lesions less than 50% of the circumference of the anal transitional zone, we can use 80% trichloroacetic acid, and you can use small local ablative therapies such as infrared coagulation, radiofrequency ablation, or electric cortical hyfrication. If it's larger, more extensive lesions, your acetic acid is less likely to be effective. So you can do it in stepwise manners where you do multiple episodes of local ablative therapies, making sure that it's not more than 50% of the circumference of the anal transitional zone, because you want to avoid stenosis. And so we can also use topical therapy such as imiquimod and 5% fluorouracil, so that will result in complete resolution of the lesions or reduction in the size, where local ablative therapies can then be used. So you can reduce the size and then ablate, or you can do staged ablations. Then looking at the perianal disease, so an example is Bowen's disease for high-grade lesions. It's similar to the intraanal lesions, where for smaller lesions, it's again the trichloroacetic acid and local ablative therapies. For larger lesions, staged local ablative therapies, and then topical therapy to downsize before your ablative measures. Then looking at your low-grade lesions, this is because based on its natural history, most of them actually tend to regress, and it's not considered a true precursor of cancer, rather a risk factor for high-grade lesions. You don't have to, you can watch, you don't have to treat asymptomatic patients with low-grade lesions. It is, some patients may elect therapy because of symptom control. So if they've got burning, itching, bleeding, and obviously if their lesions cause them psychological distress, especially anal, like condylomata, many of those want those removed, but treatment isn't indicated to prevent cancer. Then looking specifically at topical therapies, so trichloroacetic acid, good for small lesions, like I said, less than 1 centimeter squared at the base. In a retrospective cohort in 72 men living with HIV, 89 lesions were treated using trichloroacetic acid, and 80% had resolution on follow-up. And then only 2 lesions required more than 2 treatments. It's quite well tolerated, but can be painful. Then looking at 5-fluorouracil has an advantage in that the patient can apply it by themselves, and that in a 2010 trial, there were 46 men who sleep with men and who had concomitant HIV infection. They either had low-grade or high-grade lesion. Applying 5-fluorouracil resulted in a complete response in 18 and partial response in 8. So overall response rate about 57. So not the best. And the efficacy rates were a bit lower in subsequent smaller trials where 5-fluorouracil was compared to topical imiquimod or electrocautery. Then looking at imiquimod, it can also be self-applied by the patient. It's an immune response modifier. It's a toll-like receptor 7 agonist that activates immune cells. Ablation is probably more effective, and it's associated with fewer treatment side effects, so not a popular treatment. And then looking at ablative therapies. So infrared coagulation, that's direct application of a 1.5-second pulse of irradiation in the infrared range to the anal epithelium. It results in tissue destruction to about 1.5 millimeters in depth, and you get procedure-related complications such as immediate and delayed bleeding and infection in that area. And then, unfortunately, index lesion recurrence and metacoronous lesions are very common, as with all the ablative therapies. Then looking at hyfrication or electrocautery, most clinicians prefer it over the infrared coagulation. It's a faster modality, particularly for larger lesions and those that are keratotic. It's easier to use for perianal disease, and its efficacy profile seems to be quite similar. But once again, index lesions recur, and metacoronous lesions are very common. So looking at argon plasma coagulation, it's less common technique used for ablation, but in a prospective pilot studies of men who sleep with men and who have concomitant HIV infection, 65% of the participants, so it was a small study, only 13 out of 20, were clear of their high-grade lesions at their 2-year visit. And their response rates after their first, second, and third treatments increased, so from 45, 44, and into 67% respectively. So you need multiple treatments to clear these lesions. So as with other treatments, recurrences are very common, and equipment cost may be a limiting factor in APC. Then looking at radiofrequency ablation, this has been the only modality approved by the FDA for treatments of anal high-grade lesions. This lesion provides circumferential ablation to that squamocolumnar junction and seems to be effective in a small study performed at a single center. And studies of larger numbers in patients in different centers need to be performed before this technique is widely adopted, but it is approved. Okay, and then looking at HRA-directed surgical ablation. So this is high-resolution endoscopy-directed surgical ablation. So these lesions that are very large for our office-based local ablation therapies. So they use a combination of initial high-grade, high-resolution endoscopy with surgical destruction in theater, and then followed up by the smaller office-based ablation techniques. Just to be clear, HRA-guided surgical destruction is ablation, so it equals to ablation, unless there's concern for invasive malignancy, in which that case excision is attempted. So in a retrospective review of experience with 246 patients treated at the University of California over a 10-year period, 81% were treated with a single surgical procedure, 57% did develop recurrence at an average of 19 months after the initial procedure, so quite a high rate of recurrence, and 19% required multiple stage treatments for complete lesion ablation. So significant complications were observed in only 9 patients, and the one that we worried about is the anal stenosis. Okay, looking at endoscopic treatment, so there have been a few case reports that have demonstrated the effectiveness of endoscopic submucosal dissection for AIN and non-invasive SCC. The endoscopic findings of these lesions are quite heterogeneous. They require an arm block resection. You might miss some of the microscopic spread as well. So there are some areas that are endoscopically invisible, and thus an R0 resection may be difficult despite wide margins, and thus recurrence is also quite common. These are some of the studies that I came across, or case reports that are looking at submucosal resection for AIN, if anyone wants to look them up themselves afterwards. This is one from one of the case studies. This is showing an EMR. So you can see that nice, clear, wide resection of the rectal papillomas. Okay, then looking at surveillance, there is a high rate of local recurrence, and this mandates careful surveillance for following treatment. Most of the recurrences can be successfully managed with your office-based local ablative therapies. The optimal stage schedule has not yet been established. Expert opinion says to follow up around 4 to 6 months after you've done your intervention, and to repeat your biopsy of the treatment sites. And then you can also use anal cytology again, so your swab, as an adjunctive test to confirm your lesion clearance. Okay, so the outcome of our patient that we described in the beginning, he underwent resection by Dr. Lala, and 6 months later, he unfortunately had recurrence. And this was his biopsy, which showed an anorectal polyp showing histopathological features of squamous papilloma, showing condylomatous change and low-grade dysplasia. So as expected, he did get recurrence within 6 months. Okay, and that's my references. Okay, I'm just going to quickly show you the video. Can you all see the video?
You're not sharing it?
Okay. Try again. Can you see it now?
That's
No.
not coming.
Not come up yet. Okay. Let's see here. Okay, well, I don't know if there are any questions so far. Okay, it should be playing now.
There we go. It's coming up.
Okay.
We just need to enlarge the screen. We can't see it yet.
Okay, can you see now?
There we go.
We're
All
good, yeah.
We'll start from the beginning. So this is when he's first seeing the patient. See, this is the tip that he's used with the cap and with sufficient insufflation and retroflexion. Yeah. Okay.
Thank you very much, Jessica.
Thanks.
If you stop, yeah, that's great. Yeah, that's a fantastic tour de force on a lesion that I'm sure not many of us see very frequently, or we're probably missing it because we're not really looking for it very hard. But my first question to you is, obviously, with the cap on, and maybe, I don't know, I think Vikesh is actually there, so we can get him to speak to it. But if you were doing these lesions, which are at the anorectal margin, do you use a flexible endoscope, or is the colonoscope good enough, or a pediatric colonoscope is better? Because obviously these lesions have to be dealt with in most of them, as far as I can see, in retroflexion. So it would be interesting to know how he tackled it in that way. And obviously it must be very difficult to get actually very low because of the sphincter. So that would be my first question. Maybe Vikesh, if you can add in there, because I don't know if Jessica knows exactly how you did it technically.
Hi, Prof. Firstly, apologies if I have an erratic connection. I am abroad and my battery might die. Yeah, just a few points, and I'll address your question with the few points that I make as well. I mean, the real purpose of the talk was just to create awareness. I think it's like you mentioned, a lesion that is easily missed and probably under-recognized, and it should also, we talk about post-colonoscopy colorectal cancer, but no one ever talks about post-colonoscopy anorectal cancer, and I think it probably plays a significant role. So the idea here was to just create a bit of awareness to be create a high index of suspicion for these lesions. They are quite difficult to find, and they can be tricky to pick up, and I'm pretty sure that a lot of them go missed. And the big thing we probably confuse them from is just mucosal prolapse, or a little mucosal skin take there. So just maintaining a high index of suspicion for these lesions, I think, is crucial. I think a flexible scope is good enough to find them. when you're retroflexing the rectum, remember you have to do a full 360-degree maneuver and not just 90 degrees and look at one half or one quarter of the verge. You need to actually try and get that scope into full 360-degree motion, and that definitely will help you pick up these lesions. The second thing is, if you notice on that video as well, the first one that Jessica played, that there's actually two lesions there. The one on the opposite wall is more calcified, and that's just a calcified mucosal prolapse and not really a papilloma. We don't really have access to endoscopy, and none of us are really doing rectal swabs. But what we are all certainly doing is colonoscopy, and we are seeing a high volume of immunocompromised patients in our daily practice. So we have to maintain high indexes of suspicion for these lesions. So I think that's quite important. The second thing I just want to highlight, Jessica mentioned the JES, or Japanese Esophageal Society classification. And I am a believer in the few lesions that I have seen that these lesions can be assessed using the same technique. If you're not aware of the JES classification, I do advise you go look it up. It can be very confusing, but it's essentially a classification looking at the esophagus for squamous mucosa to look for dysplastic and malignant lesions in the esophagus. And what it looks at is something called the intrapapillary capillary loops. And you really want to just see those tiny little vessels. The simplified JES is probably the easiest one to follow. It's A, B1, B2, B3. Essentially, you're looking at those fine capillaries and you're looking for dilated, unfolded capillaries. The more dilated and the more unfolded they are, the worse in terms of dysplasia, going towards early neoplasia and then deeper neoplasia beyond the mucosal layer. So you want to see those tight corkscrew vessels. And I'm not sure if Jessica played the second video, but if she does have it, you can see that on the second video, beautifully, a beautiful demonstration of those vessels within the lesion. They can be tricky. So in the first video that she played, it's a bit more flat. In the second video, I'm not sure if she has it again. You can see more of a villus architecture, more of a frond-like architecture. And that's more typical for these papillomas. Just to remember that the other thing that can look like that is traditional serrated adenomas, and those should certainly also be picked up because they carry a high risk for progression to malignancy more than your usual adenoma. So just remember TSAs can also look very villus and frond-like. The third thing I wanted to just mention is, I know she's mentioned a lot of ablative therapies, and look, the reason also I gave this topic is it's a topic that I was very unfamiliar with. It's not taught. There's no clear guidelines. There's no clear surveillance guidelines. It just simply doesn't exist. But I think endoscopic therapy will play a big role in the management of these lesions. For me, resecting something is far better than ablating something, especially when it's visible. If it's invisible, then ablation is probably fine. But I do have my biases. You know, they say if you go to a barber, you're getting a haircut. If you go to an endoscopist, you're getting a resection most likely. So I do certainly have my biases there. Last point I wanted to make, and this is an interesting point, and Jessica mentioned that even in patients with these lesions, they still value in vaccinating them because it does reduce recurrence. So this patient had recurrence, and remember, you're not eradicating the HPV virus, so you always are going to be at risk of recurrence in these patients. So you do need to put them in some sort of surveillance program, especially if they carry high-risk viruses, the 16s and the 18s, the lower-risk viruses. Perhaps you could lengthen the surveillance interval. But I do think endoscopic therapies will play a big role in the management of these patients. And like she showed, there's lots of emerging evidence for all sorts of EMR, underwater EMR, EST, all sorts of techniques, essentially the usual armamentarium that we have for dealing with polyps. Just remember, again, they are at the anal verge. So by definition, they would be advanced or difficult polypectomies, SMSA plus polypectomies. Yeah, so the last thing I just wanted to mention is it's interesting. I had a chat with one of the gynecologists as well, and that also begs the question of should all endoscopists actually take an HPV vaccine? Because remember, there is transmission via inhalation as well. And we're all performing endoscopy, we're all PR patients, and inhalation might be an issue. So besides young females, perhaps all endoscopists, I think a good argument to make that all endoscopists should be vaccinated against HPV, male or female. Yeah, that's just a few comments that I have.
Thanks very much, Vikash. again, obviously, I'm not sure how many coloproctologists we have here, because traditionally that's a surgical sort of area, so to speak. And again, the worry with the anal canal is that you may not be able to access all of the canal. So I have another question, which is how would you really change your practice as a colonoscopist to ensure that you don't miss these? Obviously, if you take a decent history, you might have more awareness. But there's a few things I can think of that I might change in my practice now. And one of them is to actually look at the anus with the light of the colonoscope rather than insert it into the anus, and to make sure that there aren't external lesions. Because very often there's evidence of external disease. And I think it's important to do that. So I think it's a good thing to do, to have the light on and to actually inspect it, not just simply do a rectal in the dark, so to speak, but to actually look at it. And I'm very interested. I know the short cap is very popular, but there are some individuals who believe you can inspect the actual anorectum or the actual sphincter area better if you wear a cap, because the cap will keep it open for longer. So what's your thoughts on, at least at-risk patients, of putting a cap on the colonoscope? Certainly something that seems relatively easy to do. Again, perhaps you need a high index of suspicion to do it.
Yeah, I agree with
What are
you
your
firstly on
thoughts
the
on that?
point of looking for external lesions. I mean, of course, if there's external lesions, your risk of internal lesions are a lot higher. Just to be careful, the ones that I've resected actually had no external lesions, and they were all only internal. So just be aware that they can also, just present with internal. I think the cap definitely makes a difference. It just keeps the mucosa off the lens so you can visualize the area better. Don't think the cap should deter our pickup rates. But certainly, if you are doing interventional endoscopy and you're resecting them, the cap definitely makes it easier to resect these lesions. It just keeps that mucosa off the lens, so you don't get white out or red out or whatever it may be, and you can actually visualize that area a bit better. I think we all do retroflex, but it's almost as if we just retroflex to look for hemorrhoids and then call it that. The key is to do a full 360 when you're retroflexing and get down to that verge and actually make sure that you see the anal verge in forward as well as retroflexion. Because like you're saying, we tend to insert the scope in and you're probably halfway into the rectum before your eyes are open and you see something on the monitor. And the idea is to actually be aware and look at the monitor from insertion, or whether it's insertion or withdrawal, but look carefully at that verge. I think we should make it routine practice to actually look at the anorectal junction and analyze that area. I do think it can be found. They can be found without a cap, but I do also believe a cap definitely enhances your ability to find them, and most certainly, in my opinion, enhances your ability to resect them.
Thanks, Vikash.
Sandy,
Yes.
thanks,
ahead.
Jessica. Excellent. And Vikash. Sandy, I think the best index of suspicion is the feel that you get on rectal examination. There's a certain grittiness or a certain the texture that you feel after many rectal examinations prior to colonoscopy. All the anorectal cancers that I've detected have virtually been when you go back and you retroflex, I would have missed them had it not been for that feel on the rectal examination which precedes the colonoscopy.
So, I mean, it's hard. Sorry, I'm going back to my old surgical days when I worked and did proctology on a regular basis when I was a trainee. But again, sort of when we were doing all these operations, we had a fully relaxed patient. The anal sphincter is relaxed, and again, that it must be an issue when you inspect it, because there is about 8 millimeters or a centimeter that you cannot actually see when you retroflex for sure. And the cap on the way out would actually allow you to see that, because it's going to keep that open and you still have a visual view. Whereas if you don't have the cap on, the anus will close on the scope and you won't see that very important transition area. So yeah, I think putting the cap on, especially in high risk groups would be a good thing to do. Any other questions from anyone else?
Sorry to interrupt, Jessica. I'm not
Yeah.
sure, you might have already played the second video, but do you have that video? Because I think that illustrates it very well on what good vision you can get with of these lesions, especially with a KEF. Do you mind playing it?
Yeah,
Okay.
please go ahead, Jessica, if you can do that. You need to share your screen again.
Yeah, I have to go fetch
And
that.
I know how you're
So-
dreading that, but I'm
I'm
sure
like-
you have a go.
So just to
Yeah.
highlight something as well between the first video and the second one that Jessica is about to play is the first video, unfortunately I don't have a scope which has the capability of doing near fake focus. The second video, you'll see the type of imagery you can acquire when you have a scope that has the capability to do near focus. And I think most of us using Olympus scopes, the HQ190 series or the DL 1100 series, they all have near focus. It's just a matter of being able to know how to program it onto your scope and how to use it. And I think you'll beautifully see the difference between the first video and the second video.
Okay, let's see if I can get this video on now. Okay. There we go. See it nicely. It's too small.
Maybe you can give us some commentary.
So yeah, initially I was actually struggling to
So-
get to the lesion and actually get the scope there, and you can see that it can be difficult to get that full 360 view of the rectum. And the other thing you can see that I'm using that can help you is water. So water just helps to open up things, and it just helps to make things a bit more visible. And you can see what sort of imagery you get just putting a bit of water in. So if you have a foot pump, or even if you don't, using a syringe and using a bit of water in the area, yes, you will be creating a bit of a mess, but you will get also a much better view. So there you can see in the 9 o'clock position, the papilloma. And this patient actually wasn't so good to visualize in the retroflex view. It was actually better visualized in the forward view. When you are resecting these patients, you also do want to do it in the forward view and start at the anorectal verge and then resect them going to proximally into the rectum. But again, remember that there is also pain receptors at that anorectal junction. And if you are experienced and if you are going to be resecting them, the patients are going to feel pain. So be aware of that and adequately warn your patient and give them adequate analgesia afterwards. So you'll see in these pictures that you can beautifully see those intrapapillary capillary loops, and you can get quite good imagery of them. And I think that holds the key into deciding whether these lesions are dysplastic or actually malignant or not. Those nice tight little loops, those are what you want to look for. The bigger and more dilated they are, those are the things that should alert you towards dysplasia and also invasive malignancy.
Can I ask a
So this
question
is
of you,
forward view with the
Cash?
Yep.
Can I ask a question of you? Again,
Sure.
this the newer Olympus scope is the one I was aware of the capillary classification. But you can see it on a standard 190 or perhaps
You
see
can
it.
see it on the standard 190. So this is a standard 190. Although remember there's two 190s. You get an H190 and you get an HQ190. The Q
Yeah.
means you essentially have near focus or dual focus. The
Yes.
H190 doesn't have near focus. So it is appreciable on the H190 as well. But with near focus, it just opens the curtains in the room and sheds a lot of light.
Yes.
And I mean, you can look at the type of imagery you can acquire with it. You can see it with the 190 without near focus, but it's not so easy to appreciate. And that's
Yeah.
essentially the same thing you want to look for in the esophagus. I think we miss a lot of early esophageal lesions as well.
Yes.
And
But
that's just remember it's for
the
squamous,
resolution
not
of the new platform, the new Olympus platform
yeah,
is
so the
much
new
better.
platform, the EZ1500, that's, I mean, miles apart. So this is not the new platform. This is the HQ190 that I was
Yes.
using. But
But-
that new EZ1500, that's, I mean, the detail you get with that is just on another level. And they all do have, all of the systems have great resolution. The Pentax Inspira, the new
Yes.
Fujis, they all do have quite great resolution. But this is not the newest system. This is the HQ190. This is
Sure.
probably what most people are using.
Yes, no, for sure.
Want to see more of it? I'm gonna stop
Sorry.
sharing.
And Sorry, one further question. I'm sorry to hog it, but what are you going to do with the patient now that you know he's got recurrence?
So I've advised him to take the vaccine. I prescribed it to him. Although if you see his first histology result, he had a low risk strain, so it's actually unlikely that he develops a malignancy. I think he was, can't remember exactly. I think he was HPV-8 positive. Again, there's no clear guidelines. Essentially, what I did is repeated the scope after 6 months, and I intend to keep him on a surveillance program. The question is how often to survey him. Again, there is no actual clear guidelines on that. I'll probably do the next scope at a year and then decide from there.
And when would you get a surgeon to do a anorectal procedure? Do you think it's worth that, or is it just a field of change? When would you invoke a surgeon?
Yeah, to be honest, again, I don't think there's a clear answer to that, but because he has a low virulence strain, I wasn't as concerned, and he is under surveillance, so I wasn't as concerned. But I think if he's got a high virulence strain, then that's certainly a consideration. But again, you should actually chat early on if you're a medical gastroenterologist, your colorectal surgeon, and these patients really should be discussed as an MDT with involvement of both parties from the outset.
Yeah.
I did actually speak to the colorectal surgeons about this patients, and I actually spoke to the gynecologist. I sought a lot of advice from the gynecologist because they a lot more adept at dealing with these patients than we tend to be.
Yes, no. I think it's an area that's in the vicinity of their cabbage patch. So I think, and they know far more about cytology and interpretation of cytology and cytological lesions and anoscopy than we do. So yeah, I think it's a good thing to have them at the MDT when you've got one of these things. Right, have we exhausted? We've exhausted our time, and we've exhausted Jessica, and Vikesh has managed to come in from Mauritius. Thank you very much for doing that. And I think it's a very interesting topic and one we should just be aware of. So on that note, I'd like to thank everyone. Just to make note that these recordings will be available on the website, and to thank our two girls in the background, Cheryl and Karen, for helping sort us out and keeping us on track, and to all the New Mexico and India Echo group who facilitate this. And again, there will be, I can't remember what the one is next week, but there will be one next week. So please tune in for that. And thanks again to Jessica and everyone else. Bye-bye.
Bye.
Thanks, Jessica.
Bye.